morning, everyone. Welcome to the Thomas E. Golden Jr. Fellowship in Faith and Science. Tom Golden, for whom this building is named, had a love for the questions that arose at the intersection of faith and science. Today, we continue his inquiry through this series. Tonight, it's my pleasure to welcome Father Michael Rozier. Father Rozier is currently serving as Assistant Professor of Health Management and Policy and Healthcare Ethics at St. Louis University. Father Rozier entered the Jesuits after receiving his bachelor's degree in chemistry from St. Louis University. He earned graduate degrees in philosophy from the University of Toronto, in international health from Johns Hopkins, and in moral theology from Boston College. He received his Ph.D. in health management and policy from the University of Michigan. He also served as an ethics fellow with the World Health Organization in Switzerland. Father Rozier's research focuses on the emergence of new ethical questions related to population health strategies and the rhetorical methods used to advance health policies. Father Rozier has long worked directly with communities of need, including the homeless, incarcerated, and refugees, both in the United States and in Latin America. He currently serves on several advisory boards for Catholic Health Association. It is my pleasure to welcome him as he addresses the topic, Reforming U.S. Healthcare with the Grace of Imagination.
Thank you very much. It is a true pleasure to be here. I first want to express my thanks to Thomas Golden and his family, whose generosity makes this fellowship possible, and to the parish community here at St. Thomas More for engaging our faith in a way that makes it more credible in the modern world. Underlying this evening's talk is the question that motivated Mr. Golden to endow this fellowship in the first place. Can 21st century science bring us closer to God? Let me first suggest how I'm thinking about the two central parts of this question this evening. 21st century science. My disciplinary training is in public health and health management. I therefore wish to explore this question through the science of public health and its growing role in our U.S. healthcare system, and our closeness to God. This evening, I will suggest that the way we organize ourselves, the way we choose to live together, shapes who we are as individuals and as a community, and therefore has the very real possibility of bringing us closer to God. With that as the background, I now begin with the two questions that will serve as the focus for this evening's conversation. First, what does our health system say about us? And second, how might we build a system that better reflects who we are called to be? To answer these questions, I've divided the talk into four sections. In the first, I'll describe the assumptions that I'm bringing tonight. In the second, I'll describe what are widely considered the goals of any healthcare system and some of the modern concerns related to these goals in the United States. In the third section, I'll provide a brief description of Ignatian spirituality, specifically Ignatian imagination. And in the final, I'll bring Ignatian spirituality to bear on the modern concerns of U.S. healthcare, describing specifically the connection between how we live together and its influence on self-identity and our relationship with God. We will have time at the end, hopefully, for some conversation. So to remind each of us, including myself, of the questions for this evening, what does our healthcare system say about us? And how might we build a system that better reflects who we are called to be? To begin, I offer you a premise and a proposal. The premise is that our social institutions reflect our values. These include our systems of politics, criminal justice, healthcare, education, transportation, and much more. These social institutions are obviously larger than each of us individually, and can often feel separate or apart from me personally, but they don't will themselves into existence. We do that collectively, and we maintain them either by passive allowance or active choice. Of course, there are many situations where we as individuals, or even a large percentage of the population, disagree with the dimension of a social institution. but for the most part, the institutions in which we are embedded reflect back to us the values we use to create them. For example, our primary and secondary education system. We guarantee universal education, which reveals our value for the fundamental importance of education for an informed citizenry. At the same time, that we finance our education system through property taxes contributes to the inequality in education we see across our communities. So this institution of education reflects back to us conflicting values of universal importance, but with an acceptance that social class can determine the quality of education children receive. Or we can look at our transportation system, largely designed around the automobile, with comparatively little attention to cycling or public transportation. This social infrastructure reveals our values of individualism, convenience, and speed. Of course, these and every other social institution have complex histories that shape how they've come into being and contribute to why they're maintained. The premise, however, is that these institutions are shaped by and shape our values. It is cyclical. Our collective values first influence what kind of systems we build, but then the systems themselves start shaping our collective value system. As a scholar, I'm concerned with our healthcare system and its performance. But as a citizen, as a human being, as a person of faith, I'm concerned with how our healthcare system shapes who I am, who you are, and how we live together. So that's the premise. The proposal is that technocrats won't solve the problems with our social institutions. We must cultivate expertise in education theory, in engineering and supply chain management and finance, all the other skills that go into making our social institutions work. And we need this expertise to identify and resolve problems as they arise. But we also need to cultivate imagination, new ways of seeing ourselves and our world, which open us to problems that we didn't see before and allow us to consider new solutions. We have several examples just in healthcare where it was imagination and not technical expertise that moved important problems into our collective consciousness. It was religious women in Ohio who first admitted individuals suffering from alcoholism into their hospital. Before these Sisters of Charity insisted that alcoholism be treated as a disease, it was merely written off as a moral failure. The same story can be told of HIV, mental health, hospice care, and many other parts of healthcare. We eventually needed technical expertise to determine how best to respond to these many needs, but it was imagination, a new way of seeing people and seeing the world, that allowed us to pivot from what had been to what could be. So as a scholar, again, I'm concerned with the technical aspect of our healthcare system and the ways to solve them. But as a human being, and perhaps particularly as a Jesuit, I'm concerned about whether we are cultivating our collective imagination to shape our system in ways that truly reveal who we are and who we want to be. The second part of the talk this evening, we now move into the specifics of healthcare, and in particular, the healthcare system in the United States. There are 4 core measures of every healthcare system: access, cost, quality, and equity. These are the 4 goals or outcomes against which we measure whether any healthcare system is performing or not. So let's consider the United States in light of these. First, access. We have a mixed record of this. Since 1965, with the passage of Medicare and Medicaid, we have guaranteed access to care for certain categories of individuals: those over the age of 65, those with certain medical conditions such as end-stage renal disease, pregnant women, among others. Since 1986, we have also guaranteed access to life-saving treatment to everyone, meaning that we have universal access when one's life is in immediate danger, but otherwise not. This second guarantee creates tragic situations where someone who wants to get preventative care for their diabetes might not have access to regular checkups or insulin, but once their foot is ready to be amputated, we will provide access to that kind of care. Given how expensive modern medicine is, health insurance is an important proxy to access to care. We have improved over the past 6 years, but 35 million people still do not have health insurance in this country. The improvement from our historical high of 47 million is largely due to the Affordable Care Act, signed into law by President Obama in 2010. But in my opinion, it should not have been called the Affordable Care Act. It should have been called the Accessible Care Act, because its emphasis was on increasing access through modifications to the private insurance market and through expanding Medicaid. It is true that access and cost have an important interaction, but the ACA did very little to directly address the issue of cost. Which brings us to our second core measure of a health system, cost or efficiency. With this, we are concerned about getting a good value, a good return on our investment. Here, the difference between the United States and other industrialized economies is striking. We spend a larger percentage of our economy on healthcare than any industrialized economy. Nearly 18% of our GDP, which is well over $3 trillion. The next highest countries clock in around 12% of their economy, meaning they have thousands of dollars per person per year, which they can spend on something other than healthcare, like education or transportation or food systems. There are many reasons for this difference. More than most, we allow private companies to profit in health, especially pharmaceutical companies, where many have staggering profit margins of up to 40%, far greater than any other major sector of our economy. In addition, we cobble together multiple kinds of payers, which creates tremendous administrative waste. We have regulations that prohibit federal agencies from considering the cost effectiveness of new technologies and treatments before approving them. We focus on specialty care over primary care, and so on. Ultimately, I believe our problem with cost comes down to our inability to have a public conversation about priorities and the stubborn belief that healthcare can function as a free market. Now, it might be worth spending more on healthcare than any other country if we get the best outcomes, but we don't. Which brings us to our third measure, quality. This measure is trickier than others because there are so many ways to assess quality. Most would agree if you need specialized care and you have the resources, there's no better place in the world to be than right here. Almost 4 years ago, my brother was diagnosed with an aggressive form of lymphoma. He is well insured and he has great social support. There was no better place for him to be than the United States. That story is true for many aspects of our healthcare system, but that does not mean that we have the highest quality care in the world. In fact, when you look at population level measures, it is a different story. Life expectancy is 4 years less in the United States than it is in Canada. And for the third year in a row, it has declined. Maternal mortality is 3 times higher in the United States than in Canada, and is even higher here than in Iran and Turkey. And we likely know the challenges we face with diabetes, cardiovascular disease, and many other population-level assessments, which show us much worse off than peer countries. Additionally, the Institute of Medicine, now the National Academies of Medicine, published a seminal report nearly 2 decades ago, which said between 44,000 and 98,000 people die every year from medical errors. Even the lower estimate means that more people die from medical error than motor vehicle accidents, breast cancer, or AIDS. Improvements have been made over the past 2 decades, but error in medical care continues to be a stubborn problem. The final measure is equity. This assesses the degree to which we have avoidable differences in health outcomes across populations. These differences are present everywhere, even the highest-ranked health systems in Scandinavia. Social class always has a strong influence over health status, no matter where one goes. This was first shown in the famous Whitehall study of British civil servants and has been replicated ever since. The question is whether the magnitude is greater in the United States than elsewhere, and sadly, here too, it is. We might look at equity in two different areas related to health. First, in clinical care. Second, in the broader determinants of health, such as safe housing, access to healthy food, and good education. One example is comparing insurance status across racial groups. Non-elderly whites still have higher insurance coverage with 8% uninsured, compared with 17% of Hispanics and 12% of blacks. We might also compare access to care based on type of insurance. Those on Medicaid, for example, are much less likely to receive standard of care for many diagnoses and less likely to be able to even get an appointment with a mental health professional. But concerns with equity go well beyond clinical care itself. There are larger social factors that influence our health in meaningful ways. To illustrate, let me ask a question. What is a better predictor of your life expectancy? Your genetic code or your zip code? Absolutely, your zip code. Whether our neighborhoods have safe parks to play in, whether our jobs pay a living wage, whether our housing is up to code. These collectively have a much larger influence on our health than our genetic code, and even a larger influence on our health than the medical care we receive. And our social resources are distributed quite unequally in this country, which has significant implications for equity in health. There are a lot of policy concerns related to these four categories, but before we get there, I'd like to suggest more fundamental challenges. For example, we have basic disagreement about the role of government in promoting the health of the population. I think we also have a basic inability to admit that life involves trade-offs. In healthcare, for example, we want people to have care when they get sick, but we want people to have the freedom to get coverage or not. Both at the individual and collective level, this doesn't work. We have to choose. So there are important changes to policy and practice needed to improve the areas where we know we fall short. But I think the greatest challenge is assessing the values that we embed in the system itself. And hopefully, as we move through all this information on U.S. healthcare, our two guiding questions are in the back of your head. What does our healthcare system say about us? And how might it better reflect who we aspire to be? The third part, my favorite, Ignatian imagination. To help us answer these questions, I invite us to consider the gift of Ignatian spirituality. One of the key elements of this spiritual tradition is our imagination. In the spiritual exercises, which often take the form of a 30-day silent retreat, retreatants are asked to enter into the moments of the life of Jesus. We use our imagination to place ourselves in the gospel story and to allow it to unfold, similar to how we watch a movie. Often we place ourselves in that movie. Sometimes it looks and feels quite similar to what we've heard and read over the years. Very often the gospel story takes on a life of its own. Like all other Jesuits, I made the spiritual exercises during my first year of formation. In one contemplation, I remember being pulled aside by one of the disciples and being asked why I was there with Jesus and the apostles. As in, what was I really trying to get out of this relationship? We went back and forth, and I went through all of the doubts that had been plaguing me about my vocation to the Jesuits. In this imaginative moment, I was able to see that my doubts were just excuses, and I was able to walk up and have a conversation with Jesus himself. It was during that conversation, during that imaginative moment, that my doubts about this vocation began to slip away. Those who have made the exercises could offer hundreds of examples themselves. Ignatian imagination has a way of pulling us out of ourselves. We have less control over the situation. We entrust ourselves to the moment and allow God to invite us to consider ourselves and the world in a way that we might not be able to do on our own. The grace of imagination is also a thread that runs throughout salvation history. If we think of Moses' chief task with the Hebrew people, it was in part freedom from the oppressive Egyptian regime, to be sure, but it was helping the enslaved imagine their lives outside of Egypt so they could take the very real risk of fleeing and wandering through the desert. When Jesus called his first disciples, the primary grace was imagination. Here were fishermen and tax collectors who had likely never considered leading a worldwide religious community, who probably hadn't thought of preaching and healing. But here comes Jesus, not just to give them the skills, but to say, imagine yourselves doing things you've never thought possible. Imagine the world in a way you've never seen. As many of us entered into vowed life, whether as a husband and wife or a vowed religious, I would suggest that the grace that led us to that moment and carries us forward is the grace of imagination. We can't possibly know or plan for everything that comes. Very few of us, quite frankly, can explain with precision why it is we end up where we do. But we find ourselves daydreaming about what could be. This is fed by the grace of imagination. I believe to fix our healthcare system, and it needs to be fixed, requires the grace, the cultivation of this imagination. Quite honestly, asking for the grace of imagination and desiring to see the world in a new way. This does not mean that policies and processes aren't necessary. They absolutely are. The vocation of marriage isn't just imagining being together. It's doing laundry and scrubbing pots and maybe changing diapers. But all of that becomes rather mundane without being able to see how it contributes to a larger story. The horizon for all of this is God's kingdom and our flourishing, and the details are how we keep moving forward toward that horizon. Allow me to recount a story that you've likely heard before. A man was going down from Jerusalem to Jericho and fell into the hands of robbers who stripped him, beat him, and went away, leaving him half dead. Now, by chance, a priest was going down that road, and when he saw him, he passed on the other side. So likewise, a Levite, when he came to the place and saw him, passed on the other side. But a Samaritan, while traveling, came near, and when he saw him, he was moved with pity. He went to him and bandaged his wounds, having poured oil and wine on them. Then he put him on his own animal, brought him to an inn, and took care of him. The next day he took out 2 denarii, gave them to the innkeeper, and said, "Take care of him, and when I come back, I will repay whatever more you spend." Which of these 3 do you think was a neighbor to the man who fell into the hands of robbers? He said, "The one who showed him mercy." Jesus said to him, "Go and do likewise." This parable at the heart of Catholic healthcare reveals important values. When someone is suffering, we want them to be cared for. We know that ignoring those in trouble, passing on the other side, is not acceptable. But now I'd like to tell you a parable of my own. A man was going down from Jerusalem to Jericho, and he arrived safely. This is because as he passed along the road, the streets were well lit, there was a strong sense of community, and those who would have robbed him didn't need to because they had jobs with adequate compensation and benefits. Go and do likewise. Now, admittedly, this parable is far less compelling, and largely because it's not divinely inspired. But as someone who works in public health, I'd like for this kind of story to be just as moving as the original parable. Because this is one of the challenges that healthcare that we just can't seem to solve. It's far more moving to see someone sick and have them cured, literally getting out of their deathbed and walking home, than it is to keep them from getting sick in the first place. Or how about this one that, again, is not actually found in the Gospel of John? When Mary came where Jesus was and saw him, she knelt at his feet and said to him, "Lord, if you had been here, my brother would not have become so sick. Please do something, do anything." When Jesus saw her weeping and the Jews who came with her also weeping, he was greatly disturbed in spirit and deeply moved. He said, "Your brother does not need anything except to rest and to be surrounded by those who love him." Jesus began to weep. So the Jews said, "See how he loved him." But some of them said, Could not he who opened the eyes of the blind man do something to prolong this man's life?" Then Jesus, again greatly disturbed, came to Lazarus' room. Martha, the sister of the sick man, said to him, "Lord, he will no longer recognize you. He is too confused and tired." Ignoring her concern, Jesus sat down beside his friend and touched his hand. Jesus and his disciples stayed there for 4 more days until Lazarus passed away in peace. At the moment of his death, Jesus looked upward and said, "Father, I thank you for having heard me." When he said this, he cried out with a loud voice, "Lazarus, go to our father in peace." Jesus said to those around him, "Unbind yourself and let him go. He, like all of us, shall rise again on the last day." Although this kind of good, peaceful death does not appear in the Gospels, I have to imagine that Jesus was with some who died, perhaps even his father Joseph. How would hearing such stories shape us? How might we build systems that reflect a fuller range of our values if we had those moments in our collective moral imagination? So now the fourth part, reimagining our healthcare system. I hope the central takeaway of this evening is this, that our values and our system have a cyclical relationship. One reinforces the other, and it's one that can be disrupted by our imagination. So if we want to see changes in our system, those changes are unlikely to occur if they're merely technical in nature. We actually need to invest in our moral imagination of who we are as individuals and as a community, and have a fuller consideration of our value system. This is how I believe the science of public health can actually bring us closer to God. Public health challenges much of the prevailing wisdom of our healthcare system. And if our system more fully embraced public health, we as individuals and a community would more regularly be exposed to the values that better reflect who we were created to be. I realize this is a major claim, so let me explain a little further. As I mentioned earlier, our system is plagued by inequity. Public health's call to invest in the broader determinants of health is essentially a path toward equity, because we know the communities most likely to benefit from healthier food systems, from more affordable housing, from better employment, are those at the lower end of the distribution of health outcomes. Public health is about creating opportunity, creating environments adequate for health, and then giving people the choice to act upon it. But too often, the environments we create leave little real choice. Public health also helps us recognize that we should not be reduced to our biology. Some of the most fascinating research about well-being right now is focusing on the importance of relationship, of meaning and purpose. This is getting increased attention because of the rise in what are called diseases of despair, most prominently the opioid crisis, the dramatic rise in suicide, especially among the young, and the rise in loneliness, especially among the elderly. Population-level studies are helping us see more clearly the effect that relationships and a sense of purpose have on our biology. And therefore, solutions to these crises must be social, must be rooted in how we choose to live together. Jesus told the parable of the Good Samaritan in response to the question, who is my neighbor? He was clearly pushing us to have an expansive notion, an expansive imagination about the answer to that question. Our response to that question either draws us away from God or closer to God. In a very technical sense, let's think about the way insurance risk pools, one of my favorite topics, shapes our understanding of who our neighbor is. Before the ACA, people with pre-existing conditions were often excluded from insurance risk pools. Such people are obviously more likely to be expensive, and therefore they raise the risk and therefore the cost for the rest of us. Who is my neighbor? For whom should I care? I suggest that the way we design risk pools can shape the way we think of that question and therefore influences our closeness to God. I'm not suggesting that there is a single right way to design insurance, but I am suggesting that the way we do it matters. It matters because it shapes our sense of sacrifice, our commitment to solidarity, our understanding of vulnerability, our moral being, and therefore our closeness to God. As I begin to wrap up, I'd like to consider 3 general ways in which we can be closer to God. By coming to know and love individuals, including ourselves, by coming to know and love the human community, and by coming to know and love God's creation. Now, of course, these aren't the only ways to be brought closer to God. Our tradition has a very rich route toward that relationship. But first, being brought closer to God by knowing and loving individuals, including ourselves. This is possible in a health system that promotes the dignity of those who use it. What do I mean by this? I mean feeling like somebody created in the image and likeness of God, someone valued and respected. Erosion of dignity happens in the subtlest of ways. We've made medical facilities so complex that figuring out where to park and how to get to an office requires an advanced degree. I mean, we chuckle, but being made to feel lost and confused is undignified. We fill out the same paperwork over and over, as if every time we go to the doctor, it's the first time. Again, we laugh knowingly, but this lack of feeling known tears at our dignity. It also happens at the policy level. Medicaid reimburses at such a low amount, as I've mentioned before, that many providers can't afford to take low-income or disabled patients, even though they're often the most in need of care. So people end up getting screened based on insurance status. Imagine if the architecture, the technology, the personal interactions, and the policy were all aimed at making us feel more human. Systems shaping our values. Here, the value of being worthy of dignity and respect. And the more fully we believe that about ourselves and others, the closer we are brought to God. Second, being brought close to God by knowing and loving the human community. This is possible in a health system that promotes the common good, that directs us to contribute to the collective enterprise of each other's well-being. Our human nature is not just sacred, it is also social, which is why how we organize ourselves truly matters. I've already spoken of risk pools and the way we either allow somebody to purchase insurance or not, to be included or not. Here in New Haven and at my alma mater of Johns Hopkins, I think we also must ask why so many of our academic medical centers, supposedly contributing to the common good of advancing knowledge and educating professionals, why these centers are notoriously disconnected from the communities in which they are located. Division, inequality, lack of opportunity draws us all further from God and God's kingdom. But the opposite is also true, which is why when a health system is designed for those in most need, when they create environments for shared experience, when they orient us toward better knowing and loving each other, the system can pull us together rather than apart. And the former is where we see God. If we are to build a system that promotes the common good, I think we must cultivate a willingness to sacrifice for one another, especially the vulnerable among us. The idea of sacrifice, I realize, does not have much currency in today's world. However, we never know when or how our health will be put at risk. I may pay into a system my entire life and never have any major medical expenses. Does that mean that I got fleeced? No. That means I was among the fortunate. But I know there were others who fell on the other side of the ledger. But this instinct to sacrifice isn't always natural. We are trained to be skeptical of others who seem to be taking advantage of us. That's not a bad thing, but it must be weighed against our willingness to sacrifice, especially for those least able to care for themselves. Third, being brought closer to God by knowing and loving God's creation. This is possible in a health system that helps us to be good stewards of our limited resources. One such sign of a system is, rather than seeing technology as an altar at which we worship, technology being placed at the service of our desired end. One of the beauties of public health is its promotion of low-cost, relatively low-tech solutions. Clean water, sanitation, seatbelts, fluoride, vaccines. These have been the difference makers in increasing life expectancy over the past 100 years. Healthy food systems, clean environments, our social connection are just some of the major gaps in our health ecosystem that can be achieved by looking somewhere other than more consumption. If we are to build a system that promotes stewardship, we must also resist the narrative that death is the enemy. We should be deeply committed to life, but that does not mean we have to warp our understanding of death. Our health system has created a situation where death is often seen as a failure. Patients, their families, and providers all fall victim to this temptation. We push and push partly because we're obsessed with control and a narrow understanding of success. But it does not have to be that way. One of the best advancements in our system in the past decades has been the broader use of hospice care. But we have a long way to go to create a system where we promote and protect life, but also see death as its natural progression. So dignity, common good, stewardship, I provide these as starting points that align with who we might aspire to be and be drawn closer to God. You might note that these values map fairly well on the measures of a health system I mentioned earlier: access, cost, quality, and equity. If we get the values right, we will perform well in these important areas. You've likely noticed as well, as we near the end of the presentation, that I have spoken very little about the specifics of policy prescriptions. This is not because they aren't important. They are absolutely essential. But we often start there rather than end there. I beg us to start elsewhere, with the values that we want embedded in the system. Again, what does our current system say about us, and how might it better reflect who we aspire to be? The coming year will once again see much debate on the right structure of our healthcare system. What about Medicare for all, for example? Many believe that this is the balm that will cure all ills. And while I believe there are many things to praise in a single-payer system, moving in that direction without addressing other key concerns could be a real problem. On the other extreme, there are those who continue to believe that the market can solve most of our healthcare ills. But I must say that ship has sailed. When Bill Clinton proposed a national health plan, the Republican counterproposal was market-based. And when Barack Obama designed the Affordable Care Act, he largely adopted that Republican market-based policy. Let me say that again. Barack Obama's health care reform was as market-oriented as any serious proposal in the past several decades. And yet, for political reasons, it was just decried as socialism. The problem is that the market can't deliver on key desires, such as insuring people with pre-existing conditions. I briefly mentioned some policy, but I haven't even touched on the politics, which is another fascinating part of where we've been and where we will go. I'm happy to have that as part of our conversation. At the same time, though, I'd like to suggest, again, that this is all secondary to the more fundamental question of discussing the values that we want embedded in our system and the more fundamental task of cultivating the imagination to consider such a system and what it might consist of. Saint Irenaeus said, "God's glory is the human person fully alive." What we seek here this evening is giving as many people as great a chance as possible at living their fullest life, a chance at living out the potential God gave to them. We must put politics and policy at the service of this core truth. So can 21st century science bring us closer to God? More specifically, can the science of public health bring us closer to God? Our healthcare system needs to be reimagined. Yes, because it doesn't perform well, but more importantly, because the system itself doesn't help us become the fullest versions of who we were created to be. The values that it reinforces are too often not the values that we should hold most dear, but a different system is possible. One animated by a more vibrant moral imagination and one more grounded in the science of prevention and population-level care. Imagination, values, and social systems. They either create a virtuous cycle or a vicious one. If we build a virtuous one, it will draw us closer to God. I have tried to suggest that the only way for us to move forward is for us to step back and better consider the deeper questions that are ultimately shaping our healthcare system, and to realize that our healthcare system is shaping who we are. My hope is that we can imagine a healthcare system that reminds everyone who enters it that they are sacred, worthy of dignity, a system that brings us together around a common purpose, and a system that wisely uses the many gifts we have been entrusted with. It won't happen easily, but it is possible. Thank you.
Thank you, Father Michael. We have time for questions, so please come up to the microphone. To get you started, though, how do you cultivate imagination in your own students?
Wow, great question. So now, see, my students might be viewing this video, and then, so I can't really lie. So one of the things that, so I teach ethical leadership for our Masters of Health Administration students, so ones who will be leading healthcare systems. We spend the first 2 full weeks on interrogating their value system. So we don't jump into any kind of policy or process or anything until we reach the 3rd week. And that is because I want them to get used to knowing how they react to things, what values they bring into conversations, and then also to respect the values that other people are bringing into things, and then to have those tough conversations where they challenge themselves and they challenge each other in a respectful way. And so, well, I mean, if it weren't class, I mean, I do teach at a Jesuit Catholic university, but I don't lead them in prayer. I think the most important way to cultivate imagination is in prayer. But if not formal prayer, meditation, contemplation, and being willing to ask the tough questions of ourselves that we ask of each other.
That was really quite a wonderful and thorough assessment of the healthcare system in America.
Thank you.
I've lived my life in medicine. I'm a graduate of Johns Hopkins, and I would agree with you as to the assessment that the problems in their own backyard appeared not to involve them. Mm-hmm. But one of the reasons I come to St. Thomas More is actually it exposes me to a literature that I don't have in my life as a professional. And so I try to come here early on Sundays, and I visit the library, and I read Catholic literature. What I am left with, however, is how sparse, how infrequent is any attention that is given by American Catholicism to health care and all of its problems. Mm-hmm. It is so striking to me that the Church could be so powerful in mobilizing this country to address this problem. Your talk this evening, it should be universalized in Catholic churches throughout America. And I guess what I keep asking myself is, why does the Church avoid what it is? Is there social, religious, spiritual responsibility to change the way in which we take care of our patients in America?
Yeah. That is a great question, and especially given the history of Catholic healthcare in this country, and quite frankly, the current status of Catholic healthcare. So historically, some of the most important work in public health and healthcare was done by women religious in the 19th century. I mean, dealing with cholera epidemics in major U.S. cities. The first real health insurance was Benedictine sisters in Minnesota. And so we have a history of being on the cutting edge of healthcare, and I continue to believe that that's where we could be. I think, not unlike other situations, there are things that bog us down. So before I criticize Catholic healthcare. I'll use the Jesuits in our institutions as an example. I think we get bogged down by institutions, by brick and mortar, in a way that our predecessors likely did not. So they looked at communities and responded to the needs, and if that ended up building a hospital, great. If it ended up doing something else, fine. But now we are so laden with these institutions, and Catholic healthcare is the same way. We're laden with 600 acute care facilities, 1,200 long-term care facilities that are just that are bricks and mortar. And I think we have to remind ourselves that our ministry is not a ministry of hospitals. Our ministry is a ministry of health. And if it gets lived out in hospitals, great. If it gets lived out elsewhere, please, let's move in that direction. So I think the institutionalization has made us less flexible and responsive, not just in healthcare, but I think in education, other places. And I think, quite frankly, we are now embedded in the social fabric and the power of this country in a way that we weren't not too long ago. And I think power and influence makes us far more comfortable than we ought to be in terms of our social responses and our social ministries. And so that I would lift those two things up, and there are probably many other reasons, but those come immediately to mind. My hope, though, and thank you for saying that this should that you enjoyed the talk, it's one of the reasons that I write and teach so much. It's my hope to kind of help cultivate this imagination, and I have had great mentors along the way that have encouraged me and given me the grace to do this as well.
As a nurse, I would like the day to come when people are going to receive the sacrament of the sick, that families are included into that circle. Because more and more, it is one of the things that happens with us is when we begin to talk to patients, families are, hush, don't talk about that, don't talk about that. And yet at the same time, they have to leave, go home, and the family, the patient is there with the staff, and they're pondering the questions. I think it's time for us as a church to begin to have a series of conversations about what is it that we want to talk about our lives as we go through it.
Absolutely. I almost don't want to comment on that because it kind of stands as itself as a wonderful point of reflection. I do just want to kind of amplify it by saying that people who profess faith request more aggressive treatment than those who do not. And it is just mind-boggling to me that we have done such a poor job of communicating to our faith communities about the transformative nature and not the terminating nature of death. And so I think there's great opportunity for us to, again, be leaders. And we do see glimpses of this in the hospice care space, but I think it can absolutely, grow in the years to come. Thank you for your comment.
Hi, thank you. That was a wonderful talk, very clear. I want to read it and publicize it and send it to churches across the country. I'm a primary care physician, also an alumnus of Johns Hopkins, and a public health practitioner. And you may be familiar with Betsy Bradley's work. She was here at Yale in public health. Now I think she's president of Vassar. But she looked at some studies comparing the United States healthcare system to industrialized country in Western Europe. They spend a lot more in social programs. Yeah. And if we spent similarly and less in healthcare, we might achieve some of their outcomes. I'd hate to get to policy because I love how you want to step back, but do you see any levers by which we could take some of the waste out of our system and use them in some social determinants, early childhood education, et cetera? Where does one start with that? Is it politics?
It's a great question. Yeah, and so to kind of crystallize the the premise of your question that actually if you look, so the narrative is that the United States spends less on healthcare and social services in other countries. It's actually not true. We spend the same percentage overall of our economy on healthcare and social services combined. It's just that we spend 2/3 on healthcare and 1/3 on social services, whereas other industrialized economies spend 2/3 on social services and 1/3 on healthcare. And so it's just kind of an inversion of the same total dollars. So I'm a big believer that we do not need more money in the system to actually achieve the outcomes. I also believe, quite frankly, it's going to be very difficult to wrest any money away from the healthcare system and divert it into the kind of more traditional social services. So I think where we see glimmers of hope is in the changing of payment mechanisms, like in Medicaid, where we see some states experimenting on what does it look like for Medicaid to cover housing, to cover some food security issues, to cover some transportation issues. They're essentially saying we have enough dollars in healthcare that we can shift some of them towards social services to achieve the objectives that we meet. And I think a lot of private insurance companies are seeing this same thing, that people are willing to take pregnant women and actually pay for their telephone and their refrigerator and things while they're pregnant, because they realize that having a healthy pregnancy rather than a child in the NICU is much, much better economically. So we're seeing some of this shift of dollars. I'd like to see it happen much more quickly, but that's where I would point to.
Thank you for an excellent talk. I'm wondering about if you have any suggestions about what to do with the bad actors that we've identified them in the system, particularly the insurance companies and the drug companies.
What to do with the bad actors? Yeah. So I am, in this situation, a fan of regulation, but regulation, again, based on our value systems. And so I think in the United States, we have a very strong value of capitalism. Like, we believe that capitalism is going to generate the most efficient delivery of goods and services. And so I think it's going to be very difficult to move entirely away from that, just because that's part of our collective value system, and to name and recognize that. Now, at the same time, I think we can regulate them, because I also think that part of our value system is, again, as I said, not getting fleeced. Making sure that there's a fairness of playing ground. And so I think the more clearly and forcefully we can make the argument that these pharmaceutical companies have a profit margin well above oil and tech and all these other parts of our economy that we presume are doing fine, I think we can actually shift and put in some regulation to deal with them.
Thank you so much.
Thank you very much for your time this evening.
Appreciate it. Thank you all for joining us tonight, and Father Michael will be here for a few more minutes for individual conversations, and students are invited to come to Rig Study for further conversation with him.